So next is critical care and anesthesia, and this is V1, abdominal compartment syndrome. Very important topic, and practically you have to see in your daily practice a lot in the ITU. You have seen asked to review a 71-year-old male patient in ITU who is 48 hours post-operative following a laparotomy for a diverticular perforation. The nurses are concerned that his intra-abdominal pressure is 21 millimeter of mercury, not centimeter of water. 21 millimeter mercury. What are your initial concerns? So I'm concerned here patient might be developing abdominal compartment syndrome. So I would speak with the staff involved, ITU consultants, and see what are their concerns. So after checking the ABCs, I will review the patient by looking at the past medical history, including medications, operative notes, current medications, nursing and medical notes, and the observation and fluid balance charts. Then I will examine the patient, looking for signs of peritoneism and increased abdominal girth, basal crepitation, evidence of DVT or PE. I would check his pulse, blood pressure, central venous pressure, respiratory rate, and respiratory support, including supplemental oxygen and ventilator settings, urine output, nasogastric aspirate, and most recent blood and arterial blood gases and lactate. So first I asked history. Second, I gone through his first history and notes, all the information. And second, I have objectively examined the patient. And third, I have looked all his tubes and drains and monitoring devices and the recent bloods. If patient is oliguric, I would exclude the other causes of acute kidney injury, including the prerenal, renal, and post-renal. So prerenal means patient have a shock, hemorrhagic, hypovolumic, third fluid loss, pump failure, acute MI, ACS. And interrenal is acute tubular necrosis due to hypertension and nephrotoxin. And post-renal is the catheter problem like King, clogged bilateral ureteral obstruction. If abdominal compartment syndrome is confirmed, I will inform the patient consultant and intensively assess the patient while investigating the cause. So what is actually abdominal compartment syndrome? So the definition is if intra-abdominal pressure is more than 20 millimeter of mercury by a minimum of 3 measurements conducted 1 to 6 hours apart, or single or multiple organ system dysfunction or failure which was not previously present. So these both needs to be present to label the abdominal compartment syndrome. And the underlying cause is raised intra-abdominal pressure, which in turn impairs the venous drainage, causing congestion and subsequent capillary permeability, leading to leakage of the fluid out of the capillary bed into the interstitial space. And there are two main types of the abdominal compartment syndrome. One is primary and second one is secondary. So as the name indicates, primary due to decreased abdominal compliance, presence of an intra-abdominal retroperitoneal injury or pathological process, and secondary due to any other disease. So secondary injuries include the abdominal cause fluid accumulation in the other normal bowel pancreatitis, ruptured AAA, sepsis, burns, excess fluid resuscitation more than 3 liters per 24 hours. In practice, many primary causes require fluid resuscitation and massive transfusion, which may increase the gut edema and generation of the peritoneal fluid. These patients therefore have mixed primary and secondary causes. How is intra-abdominal pressure measured? So it's measured through Foley's catheter in the bladder connected with the Y tube and consider suprapubic bone as the zero reference point, and then it's measured and it's expressed in millimeter of mercury. Its normal value is 5 to 7 millimeter of mercury. If intra-abdominal pressure is more than 15 mercury, can cause significant aortic dysfunction, failure, and patient death. So failure to intervene, intra-abdominal pressure rises about 25 millimeters with a poor outcome. There are 4 grade 1, 12 to 15, grade 2, 16 to 20, grade 3, 21 to 25, and grade 4 is more than 25. What are the pathophysiological changes of the abdominal compartment syndrome? So it involves all the system. Let's start from the viscera. So if there is more pressure in the abdomen, more pressure in the veins, what will happen? Decreased visceral perfusion and swelling blood flow, GIT mucosal ischemia leading to stress ulcer and colitis. Decreased renal blood flow and GFR, and renal impairment occurs at 15 millimeter mercury, oliguria at 20 millimeter mercury, and anuria at 30 millimeter of mercury. Pulmonary diaphragmatic splinting, decreased ventilation and compliance, decreased total volume, increased partial pressure of carbon dioxide, and respiratory acidosis. Cardiovascular, decreased cardiac output, decreased blood pressure, decreased stroke volume, increased pulse, increased internal pressure, increased systemic vascular resistance, and pulmonary artery wedge pressure, DVT due to venous stasis. And cerebral, elevated intracranial pressure, reduced cerebral perfusion pressure. When would you operate to treat the abdominal compartment syndrome? The treatment of abdominal compartment is based on the four general principles. First is serial monitoring of intra-abdominal pressure, analgesia, and correct body positioning. Number two is optimization of the systemic perfusion and organ function. Number three is appropriate medical procedure, including the treatment of underlying cause to reduce the intra-abdominal pressure and organ consequences, and prompt the surgical decompression for refractory intra-abdominal hypertension. I would use a trial of medical treatment first, using sedation, analgesia, neuromuscular blockage, full fluid optimization, and body positioning to improve the abdominal wall compliance. So this is again buzzword. I will trial surgical dissection, trial of medical treatment. I would consider endoscopic decompression and use mean for pseudo obstruction and percutaneous drainage of abdominal fluid. If internal pressure persists at more than 20 minutes of mercury, the definite treatment is surgical decompression. Should only be employed if medical treatment proves to be inadequate. Hypotension, oliguria, and elevated airway pressure resolve rapidly after the procedure. Usually, there are two main options available. Say which one you should use: Begota bag. Begota bag, pre-sterilized 3-liter fluid irrigation bag, suture a stapler to the skin, or Sunway technique, cover the viscera with fenestrated polyethylene sheet, moist surgical towels, vacuum drains, and hydroform adhesive drape. I would cover the patient with a broad spectrum IV antibiotics for the abdomen. Sudden direction may lead to ischemia, reperfusion injury. And nowadays there is a special dressing for the abdomen called Abthra. So you can apply Abthra after doing the laparoscopy. Thank you.